Sounds good. All right. Okay. How are you today?
I'm good. How are you? Thank you for meeting with me.
I'm exhausted, man. It's like my fourth interview today, and the baby's
Oh
asleep.
my goodness.
But I'm in the basement hiding from him, so I don't wake him up. This is my life now. Let me see if I can put this a little higher. I've got one of those ridiculous computers with the camera on the bottom of the of the screen.
Oh,
So
yeah.
you look up my
Yeah.
nose. It is what it is. It is what it is. You're stuck with
It
me this way.
is. That's okay. It's a COVID era, so anything
Yeah.
goes at this point.
Yeah. Ah, man. Okay. So what are we talking about again?
So, I wanted to get your thoughts on race-based data
Mm,
and collection in Canadian healthcare specifically. Before we go forward, though, I'm just gonna start recording the
okay.
meeting. Perfect. Yeah, so I'm doing an article on how systemic racism is prevalent in Canadian healthcare and how the pandemic has really shown the disparities, specifically within Montreal. But overall, I just wanted to get your thoughts
Sure.
on race-based data and like what is missing in medical
Right.
education
So
and everything like
I can just
that.
start talking and you can take from it what
Yeah.
you want. So a lot of things come to mind. First is that public health emergencies in general and pandemics specifically have a way of elucidating, illuminating, and exacerbating existing inequities in society. So it's always instructive to see what's happening. And I'm always buoyed by the possibility of addressing some of these things when this is done, but we never do.
Hmm.
So some things that come to mind first is there's a reason that racialized populations seem to be disproportionately affected by this disease and disease in general. As we know, this disease does worse in people with some pre-existing conditions, some vulnerabilities and comorbidities, and those
Right.
tend to be more accentuated amongst non-white populations for a number of reasons, mostly having to do with socioeconomic status. So, socioeconomic status is the mechanism by which this racial effect has its influence. Not entirely. There is some genetic component to this as well. There's some studies that suggest that African Americans, for example, have a different antibody response to some vaccines than non-African Americans. So there's some,
Hmm.
biological components, but it's mostly socioeconomic. So one way of looking at this disease is that it has compressed what would have been the tragedy of long-term chronic illness into the short-term acute of a, time frame of infectious disease. So what do I mean by that? A lot of Black Americans, Black Canadians, for example, Indigenous North Americans, other people of color, tend to suffer from the same kinds of chronic illnesses like obesity and diabetes, high blood pressure, things that are associated with low income and low income environments. And over the course of decades of life, they will kill you eventually.
Hmm.
It's easy to overlook that because it's a slow moving train wreck. And we can throw platitudes at it and some money here and there at it, but it's not happening in your face. What
Hmm.
this disease done has compressed what would have been a decades long tragedy into 1 year, where those people died in a short time frame, or at least suffered a great deal in a short time frame. Right.
Interesting.
So that's excuse me. That's sort of how the data seems to be manifesting. And if we look at how and why these people are suffering and how they got to this position, well, we look at things like food deserts. In the USA in particular, places like Detroit is an enormous urban food desert. It's hard to find healthy, nutritious foods that are affordable. It's strange that fresh vegetables are more expensive than dry potato chips. It's
Right.
strange that carbonated, sugary beverages are subsidized by society, whereas things that can keep you healthy, like celery, isn't. You know, so as a result, it's difficult to be fit and well fed. It's difficult to be well exercised if you are working long hours for low pay and doesn't leave a
Hmm.
lot of hours left over to for self care. If you don't have proper childcare, then that also leads to psychological stress and less time and resources available for self care. If you're low income, you're not driving to work, you're taking the bus. And for this disease, that exposes you to all kinds of potential infections.
Hmm.
If you're low income, you're probably not in a job that allows you to work from home. So you have to go in person. You're probably a frontline worker, as we call them,
Right.
cashiers and so forth, and nurses. If you're low income, you're probably have to have your kid you can't keep your kid at home from school if that's an option. You have to send your kid to school, and they might bring infection home to you. If you do keep your kid home, the quality of your Wi-Fi is probably poor. And so your kid is going to suffer, and that's going to increase the mental stress on you and your household. You probably haven't got as comfortable a household as you could to allow everyone to work from home. So the stresses mount. So at every level of analysis, this disease disproportionately affects those of low income, and low income is heavily correlated with non-white status in North America.
Correct.
Right. And then we have the vaccine. So the vaccine introduces a whole new level of racial analysis. We have a long history amongst Indigenous people and Black Canadians and Black Americans in particular of distrust of the healthcare system, having to do with really defensible positions like the Tuskegee experiment, which many people aren't that well aware of, but if you're from that community, you're probably well aware of it.
Right.
A history of government experimenting on you and not taking your needs into consideration, your health needs. So you're less likely to trust a medical establishment that magically produces a vaccine solution for you. Now, the tragedy of this is that while the U.S. data is a bit more transparent, I don't know the exact numbers, unfortunately, but Black Americans constitute a higher proportion of people suffering from COVID than white Americans, and yet they are a lesser proportion to receive and accept the vaccine.
Right.
So that's a doubling down of the suffering. And amongst Indigenous populations, the history there was pox blankets and of other kinds of subcutaneous and under the radar biological warfare. So the distrust of the medical establishment runs deep. So it's all deeply, deeply complicated. Now, if we look at the data that's available, in Canada, the data is not as transparent or easily explored, but we see diverse neighborhoods, quote unquote, as being far more likely to have high levels of COVID and to have high levels of hospitalization resulting from COVID and high levels of death resulting from hospitalizations, more so in each of those tiers, more so than in non-diverse neighborhoods. So a hand-waving argument, you can surmise that has something to do with racialization. It's not conclusive, but it's suggestive. But it's difficult to disentangle the elements of socioeconomic status, race, and other kinds of social determinants of health. So the social determinants of health include race and gender, age, social support systems, climate, environment, all that stuff. And it's all interwoven here. It's difficult to disentangle it. Some of the things that we have to look into in terms of it's easy to complain. What are the solutions here? Is we need policy levers that address the problem at its root. So among them, the paid sick leave, I think, is something that really has to be looked at deeper. And yes, I understand that the argument against it is some malingerers will take advantage of the system, but it's a strange argument to say because a handful will abuse the system, then people who genuinely need these supports will be denied it. Strange logic.
Yeah.
That's one way to do it. And why that's important is we look at the vaccine. The vaccine has pretty serious side effects for some people for lasting a day or two that may compromise their ability to go to work and take care of their kids. And so knowing that, you probably will choose not to get the vaccine if you can't take the day off work. So who does that disproportionately affect? The poor, and therefore the racialized. Right? So without even thinking about it, we are setting up a system that disincentivizes poor people from getting vaccinated and prolongs their suffering more. Right? So there's an argument to be had that the priority list for creating a hierarchy of who gets vaccinated maybe should include some of this. I'm not so sure about that, but that's an argument. So when we decide who gets vaccinated, it makes sense to do it by risk. But risk can be defined as risk of death, that means the elderly, risk of exposure, that means, teachers and bus drivers.
Frontline workers.
Or risk of infection, which is doctors and healthcare workers. So we all seem to agree that the risk of death, the risk of infection are important. Risk of exposure is a bit more complicated. And many will argue that maybe non-white people should be higher on the list. I'm not sure if that's defensible, because it makes the presumption that it's the non-white status that makes you vulnerable and not the other factors like the living arrangements and the socioeconomic status. So, but I think it is defensible to say that low-income people should, at the very least, if not moved up on the list, be given incentives for vaccination. So it's a curious position that we're in, and there's an opportunity here to examine the built-in inequities of our healthcare delivery system, so that this is not a problem for the next iteration of our public health emergencies. And I'm not sure what the solutions need to be there, but I think we have to examine them.
Right.
At the very least, collecting data with those variables checked off. Are you a low-income person? What kind of social support system do you have? What access to good quality foods do you have? What are the barriers in place to prevent you from getting access to good quality care and information? Right? And that's another part of this we didn't discuss, is the quality of information received by the people we're talking about is poor. And that is because of the bubbling effect of society. We're all in our little bubbles, and the echo chamber of misinformation. And also, if you are racialized, likely low income, you're probably low educated and surrounded by other poorly educated people who are going to amplify misinformation.
Right.
I mean, that's nobody's fault. That's just the way it is. So how do you pierce that bubble? And from where I sit, the information angle becomes more and more important. Like, we can't address anything unless we get buy-in from the people we're trying to help.
Right.
And you get buy-in through proper information. So I lectured you there for a good 20 minutes there. So if you got any questions, cut me off.
No, I think it's interesting. I also wanted to get your thoughts on the vaccine itself, because from brief research that I've done on the Pfizer and the Moderna, I think it's the Moderna that's done their testing pool on a smaller group, I believe. How does that affect? You mentioned like biological differences between people of color versus white people. How does that affect the process of the vaccine? How does the vaccine in its testing accommodate for the different biological differences and things like that? And does that add to any sort of hesitation that racialized, marginalized groups might have?
So we have to distinguish here between an actual biological effect and a perceived biological effect. So much of the diversity in the vaccine trial population, I think, is for communication purposes, to show, look, we did test it on people that look like you. So, so we should be, because really human beings tend to be human beings. We have the same organs, the same kind of blood, etc. It's just that these differences in antibody responses do exist, but they're small differences. The fact that the vaccine manufacturers went out of their way to have diverse populations is a good thing. And it was done intentionally, in preparation and an acknowledgement of the issues we're talking about here. What's also important in terms of the racial diversity is the living arrangement diversity, the lived experience diversity. How many were single mothers? How many were crowded households? How many were low income and blue collar workers? All that stuff. Scientifically, honestly, I don't think that really matters that much in terms of measurable vaccine efficacy. But if you're trying to sell this as, we tested this on people who are like you, then this helps. It might have some small effect on efficacy indirectly, like, if you live in a crowded household, you probably have certain exposures and vulnerabilities that people who don't have crowded households have. You probably have a different micronutrient level that other people don't have. You may have a vitamin D deficiency or something like that. All these things are possible. The nature of randomized controlled trials are that once you have a rich enough trial population, once you're randomly allocated those people to the treatment group versus the placebo group, then anything you haven't measured or controlled for should also be randomly distributed. So the beauty of it is, even the things you didn't think about controlling for are controlled for in the randomization process. Which brings me back to the information angle here. Is it would be great if we could double down on explaining to people how randomized controlled trials work and why there's a control group and why we randomize to account for these very things that people are concerned about. Like, for example, like, how do you know this isn't due to vitamin D deficiency? Well, I don't know,
Yeah.
except that because I didn't test for that, but I did randomly allocate people. There should be an equal number of vitamin D deficient in this group as is in this group. Therefore, any differences will have washed out.
Right.
That's the kind of thing. But the science on racial differences is evolving, and even the science of whether racial differences exist is evolving.
Mm-hmm.
And it's so laden with politics, it's unclear exactly where to land on this. From where I sit, one way to think about racial differences, they're actually collections of what's called clades, which is the way that genes manifest. So I'm a brown guy of Indian extraction. Somebody else may be similarly look like me, but not have the same background. But the collection of genetic traits are similar enough we can say that we are, racially in the same pot.
Mm-hmm.
Scientifically, that is only useful if it leads to a measurable outcome in differences, like, for example, tolerance of UV radiation, tolerance of spicy food. I don't know,
Right.
But it's the actual differences are rare. And most of the things we are talking about really are socio-demographic. They're social and cultural. They're not physical, even though the physical,
biological or anything.
I mean, there are some. They're few.
Yeah.
But they're not many. Most of this is social, and I mean, the biological differences could be things like obesity, and which is a behavioral thing to some extent, to a large extent. I mean, some of it, tiny bit is genetic, but not entirely. So I know I'm being wishy-washy here, but I'm trying to drill home the point that while biological differences do happen, most of this is socio-demographic. And the other lesson from the pandemic is that the social determinants of health matter. They really matter. So addressing poverty is probably the biggest, single most important thing we could have done to make suffering less so throughout this pandemic. That's why UBI, Universal Basic Income, CERB, was so important. Right? Once you remove the suffering caused by our public health interventions, the public health interventions can work. Okay? So you take away the effect of poverty, then everything else is on the table.
Interesting. So how can we, for like the next, I guess, global health crisis, move forward and like learn from this experience? How does the medical field take what this pandemic has highlighted and solve some of the issues that have
yeah. Well, I mean, like we talk about the racial element in a second, but the biggest thing from my perspective is the communications angle, and the racial element is built into that. So there's a paper I always cite from 2007 that talked about lessons we learned from the first SARS. 2007, 13 years ago. And there are three lessons. Number one was animal husbandry is bad for human health. We can debate that. Number two is the 19th century technologies are best. So wearing masks, hiding in your house, that works. Okay, great. I think we know that now. Number one was transparency and communication is key. We had zero transparency and communication in this pandemic, and we continue to have minimal transparency and communication. So the communications angle is so key to this. I was joking with a reporter just yesterday that the next pandemic, epidemiologists should not lead it. It should be led by social psychologists, right, who understand what the public will tolerate, what the public is willing to hear, and how best to approach them with difficult information. Because we're in a strange time in history where the reflex of people is to distrust everything coming from an expert mouth, whether it's government, media, or scientist. So how do you tell people something knowing by the simple fact that you said it, it will be poorly accepted? So that the psychology of communication really is the most important angle here. And when it comes to racialized populations, there's a different way of speaking to different people depending upon their histories and their experiences dealing with power dynamics. Right? The indigenous people hear one thing, Black Americans hear another thing, middle class people in the suburbs hear something else, blah, 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 blah. So a diversity of communication tools, of messages, and so forth is important. Combating politicized disinformation is critical too. So the hardest part of this for me has been not just combating misinformation, but realizing there are people actively fighting against me with good funding and organization to get across incorrect, damaging narratives.
Mm-hmm.
Who knew that was a thing? Who knew that was going to happen? When writing out the playbooks for dealing with the pandemics, nobody thought, oh, you're also going to be fighting with well-funded disinformation agents. What? You know?
Yeah.
So that's a huge one. And then, of course, we have this subtext of essentially a race war going on in the USA and bucking over here. And that's fueled a little bit by the pandemic when you see situations like so many of the COVID deniers, the Trump followers, are white. And so many of the people being disproportionately affected by COVID were not white, mostly black and brown. And so that, again, exacerbated that divide. And that just fed into the growing civil war that is percolating in the USA in some ways. So how do you bring people together? And there is a role here for the medical establishment to bring people together. Remember, suffering is universal. What are the common values here? We all love our children. We all want prosperity. We all want safety. We all want to be right.
Human nature.
Right. So is there a narrative that lets everybody be right? I don't know. But I think, the role of the medical establishment is to definitely not to feed these divisions. And to understand, though, that also whatever advice and recommendations and data we produce is going to be filtered through a social dynamic that results in different conclusions depending upon how you hear the message. So we're entering the era where the communications professional will lead us. Right. And scientists like myself, physicians, aren't really trained in that. We sort of stumble our way through. But I'm hoping true communications experts can figure out how to say things, how to get messages across that does not inadvertently divide a population. In my global health work, one thing I've stumbled upon is any technological solution always creates social divisions, always. And doesn't mean you shouldn't have those solutions. It means you have to be on alert for them. So things like, an example I always give is the gasifier machine, which is a machine in which you turn cow dung into electricity for free in a village. And it sounds great, except you realize suddenly the cow dung, which had no value, now is worth something, and the people who own the cows want to be paid for it, and that now there's a divide between the cow owners and non-cow owners. Okay, small example. And the solution there is you get the people who don't own cows who contribute in some way to the process. So a vaccine is a technology that solves a problem, but it too will create a division. In this case, the division is between those who believe in the conspiratorial nature of vaccines and those who don't.
Right.
And how do we overcome that? I don't know.
Yes.
I don't know. Except that over the long run, what we need is to incentivize the desire for vaccine, and to double down on the investment in science literacy. It can't be the domain of the powerful as it is now. Who learns how to organize randomized control trials in high school? Only the best high schools teach that, right? Not the inner city schools in the US. Right? So we need a better foundation of science literacy to empower everyone to navigate this process for themselves. We need to redefine what critical thinking is. Critical thinking isn't simply saying, I distrust all authority. It isn't simply saying, hey, just follow the money. That's the first steps, right? Critical thinking also includes, does this make sense based upon the laws of nature as I understand them? Right. So there's a lot to unpack there. And luckily, those of us who are science educators were probably well employed over the next 20 years trying to deal with this. I don't know. I mean, we've gone off on a tangent here. The original conversation was on the racial dynamic of COVID.
Yeah.
But I think it's intertwined with the science literacy element and the fact that all of this is being fueled by a political machine that seems to want to sow discontent.
That's, I don't know. It's interesting because I mean, I didn't really realize the lack of transparency as you were talking about before until doing this project and like diving deeper into it, and the fact that race wasn't considered. I think it was our Minister of Health in Quebec who said that race wasn't considered that much of a factor in in collecting data and things like that. And Quebec still hasn't really released any of their data on that. So and I also attended a seminar last week about systemic racism within healthcare, specifically in American context, but like, seeing where the distrust with the healthcare system stems from, and, having people being used as experiments, live cadavers and things like that, it evolves itself. And it's interesting to see how it's manifested itself into today and continues.
Oh, it's everything. And there's another element that hasn't been fully explored in this dynamic yet, is that those of us who comment on this publicly, we get attacked all the time, hate mail all the time, all this stuff. And it's almost always from a racial lens, which is curious, right? So you get the Asian experts, the Black experts, the brown experts like me. When you get the hate mail, it's always right for your race. And if you're a woman, it's always right for your gender. That's fascinating to me, right? So it shows you're going for low-hanging fruit, but also the moment there is discontent or uncomfortableness or pain, in this case, economic pain, you look for the thing that's different and blame it.
Yeah.
Like I'm thinking about my dog who's sitting next to me right now. My dog sometimes growls at my baby because my dog has, he's in pain. He has bad joints. And when he's in pain, what's that weird thing in front of me? It's got to be his fault,
Yeah.
I don't blame him. He's a dumb dog.
Yeah.
That's the attitude that we're dealing with. We find dumb people who are in pain. What caused my pain? Must be that funny looking guy on TV.
Yeah.
So this has brought racism back to old-fashioned 1940s racism back to the surface. Go back to where you came from, that kind of thing. And it's damaging for a number of reasons. Obviously, it's damaging because racism is bad and hurtful and all that, but also so many of our public health and medical experts are non-white for a variety of reasons we can get into. And if you're saying you don't want the non-white medical professionals, well, then you're in trouble, fella, because that's a pretty big portion of medical infrastructure.
Yeah.
And then we have the element of the next generation of public health leaders are seeing this and feel very cowed about being public figures now, So we are discouraging an entire generation of women and people of color from entering leadership roles of this nature. There's so much here. There's so much here.
It is. There's a lot.
I'll be curious to see what angle your article takes, because there's so much here.
Yeah. No, I've always been very interested in like racial aspects and things like that. That's kind of been my whole study. And then getting into the pandemic and how it's just, especially in Montreal too, I mean, the areas that have been hardest hit are the low incomes, poor socioeconomic environments with the heavy immigrant families and who are living in close quarters and things like that, working on the frontline jobs and things like that. So it's really been interesting to see how that's happened and how our premier has handled that and really just ignored it and cast it aside to, again, referring back to the diverse neighborhoods,
Right.
And like using those blanket statements to just...
An example of how policy sometimes is unintentionally, racist isn't the right word, but let's say racist for a second, is the lack of realization that multi-generational households exist. Like so much when we talk about households in public health parlance, we're talking about the nuclear family. And yet we have great-grandparents, grandparents, parents, and children living under the same roof in these immigrant non-white families as the norm. So failure to account for that being the norm in some subcultures is an unintentional kind of racism, right? So that's the kind of stuff we have to be on guard for. It's kind of like, defining family. A family can be, one parent, one child. One couple and a dog is a family. So we need to be more inclusive in these definitions, not just to be politically correct, but to understand it now describes the reality of our world.
Right.
So that's the key here. We have to be able to address the reality of our world, not the verbiage of the world as we think it manifests from our textbooks. So that's the challenge.
It is. It definitely is. And it's definitely going to be interesting to see how, especially how, like the bridge between, the politicians and the sociologists and the medical professionals, move forward.
Oh, they're not going
to. Well, I guess we can always manifest it. But it's gonna actually happen.
Nothing's going to happen. Sorry to say. But
Actually go back to normal. That's the
I
normal
think
we want.
the second we have vaccines well distributed and people aren't afraid to go outside anymore, we're going back to our nonsense state.
Yeah.
We'll spend maybe 5 years, the Royal Commission probably, looking at what we did wrong, and we'll end up investing in disease surveillance, which is good. We'll end up upgrading our telecommunication system to report things from the public health units to the federals faster. That's
Mhm.
good. But we'll do nothing around science literacy. We'll do nothing around uplifting the poor. We'll do nothing around addressing those chronic issues I talked about in food deserts and all that stuff. Nothing's going to be done there. Nothing around universal basic income.
Yeah.
Even though that's a huge lesson here, right? The universal that CERB worked.
Yeah.
And yet, anyway, I can rant forever.
Why not?
But
No, I think this was good. This was a really interesting conversation. This was my first one, so
oh really? Oh good.
Yes, it was.
Are you a journalism
It
student?
was. No, I'm an international development and Middle Eastern studies
Very
student.
nice.
Yes,
Very
so trying to figure out my path after graduation. See where that takes me. But yeah, so this was interesting.
Good.
I had a good conversation.
Excellent. Well, I gotta go. My baby's crying. I gotta pick him up.
Yes.
So,
yes.
No other questions? We're cool.
No, I think we covered everything. Covered everything on my notes, so that's good.
Excellent.
Excellent. It was great meeting you.
You too. Good luck, and send me the article when it's done.
I will. I'll be sure to email that to
Cool.
you.
Okay. Bye.